Thanks so much for having me. I'm really looking forward to the conversation. So yes, today I am going to be talking about long COVID, which obviously is a public health crisis at this point following the pandemic, and just talking about what we can do as data scientists, computer scientists, informaticians to contribute to the effort to combat this disease. So what you're looking at here is a COVID dashboard, which I'm sure is something that you all have as well, that just shows caseload in different areas of my state in the US, which is North Carolina. And this is a great resource. And this was really important during the pandemic, where we were able to gather together a ton of data about the cases in North Carolina and start to try to visualize patterns and start to do analysis across the state. So it's a big denominator. There are millions of people that live in North Carolina, and we can really do a lot with that. But in the very beginning stages of the pandemic, we were really asking ourselves how we go from this denominator to this denominator. And it's sort of interesting because this is the first time that I'm giving this talk internationally, and I will be really interested to hear if some of the issues that I'm talking about that helped us and hurt us in getting to this denominator are the same, and if we share issues or if the picture is completely different. I'll be really fascinated about that. But regardless, this is a very hard thing to achieve in the US because we are so decentralized when it comes to healthcare data. Academic medical centers, and frankly, all medical centers in the US, all of them have their own electronic health record databases. And if you are not familiar with electronic health records, it is essentially just the electronic system that collects data about you, as well as billing data and lab results and all the things that sort of are attached to you around healthcare, the systems that collect that when you go to the doctor, go to the hospital, et cetera. All of that data is stored in different data warehouses or databases that have completely different models, and none of them talk to each other. And that is pretty much by design. So it was about March or April of 2020 where the National Institutes of Health in the US decided to try and do something about this. The idea was that we wanted to imagine a world where we could query and analyze data from all of those locations in one big database, so that instead of having this denominator of North Carolina, we would have the entire US and all of its data to find patterns in. And that is and was the intention of N3C, which is the National COVID Cohort Collaborative. And that is an organization that I am still part of today, over 3 years later. So N3C is, first and foremost, a data resource. It is a giant database that has a ton of data in it. We have approximately 18 million patient records at this point from 77 different healthcare systems across the United States. It's also a collaborative community of people who are interested in doing analytics, particularly for COVID and long COVID research. It is funded by the National Center for Advancing Translational Science, which is one of the institutes of the US NIH. And the N3C data set, it was in 2020 and still is today a national COVID data set. It contains EHR data about patients who we know have had COVID, as well as 2 matched controls. And I'll talk a little bit more about that in just a moment. From, again, 77 healthcare systems across the country, and it is refreshed weekly, even to this day, so it's always pretty current. It is housed securely at NIH in an enclave where people can do analytics and use modern data science tools, but in a walled garden, very secure environment. And there is a website if you have additional questions about N3C. So going back to our problem where we have healthcare data scattered all over the country that doesn't really look the same, it's all fruit, but it's all different kinds of fruit. So it's very close together and you can sort of make sense of it. But if you try to smash it all together in one big database, it really doesn't fit. And so part of the effort of building N3C was making all of these slightly different variations on healthcare data fit together. One example of what happens when you have one data set that's a banana and another one that is an apple is that both of these patients in this example have COVID. This patient here has been given an ICD-10 diagnosis of COVID, which is code U07.1, and given a date. And that seems like if you run a database query, you should be able to find this patient pretty quickly. But there are other hospitals that have database formats where they don't actually store the codes directly in a diagnosis table. Maybe they code it as something else. The date format is different. They're just not the same enough. So a single query is not going to capture both of these patients, and that is the entire purpose of N3C. So to deal with this problem, we decided to work with what's called a common data model. Some of you may be aware of common data models, but essentially, common data models are used to store electronic health record data in a consistent way. It is essentially an agreement between healthcare systems that says, I'm going to store my data in this way, and if you agree to store your data in the exact same format, then when we work together, we can put our data together with much less pain and suffering than if we have to transform our data customized every single time we want to do research. So common data models were certainly not invented for COVID research. They've been around for a long time, but it seemed like a really good opportunity to use common data models in that we knew we wanted to put a bunch of data together. Now, the problem with common data models is that there's more than one of them. So we don't have all the sites in the US that have agreed to all work with the Odyssey data model or the PCORNet data model. Rather, there are some sites that have one, some sites that have another, yet other sites have a third variation, et cetera. And so when we built N3C, we decided to allow sites that wanted to participate to send us data in any one of these formats. And if they did that, we were then committed to, on the NIH side of things, bringing them together into a single format, which we chose as Odyssey. We essentially wanted to make it as easy as possible for healthcare systems to participate without a whole lot of barrier to entry, particularly early in the pandemic. Now, the next step in building N3C, in addition to deciding on a data model, was deciding how we were going to define a COVID patient. So before we can talk about long COVID, we have to talk about COVID. And in order to identify who has COVID in a database, you have to define the disease in a codable way. And the whole science of doing that is known as computable phenotyping, and that happens to be my area of interest. And so I came along in COVID times, having done work like this for diabetes in the past and other diseases, but I had never worked with a brand new disease that didn't really have a whole lot of stringent criteria that already existed to define it. So I knew I was going to have to write a computable phenotype with our team of collaborators, and that phenotype was going to have to query the EHR data to identify a COVID cohort, and it was going to have to rely on some kind of standard code set. In our case, that would be either ICD-10 for diagnoses or SNOMED for diagnoses. So I knew I was going to have to find a standard code that was equated to COVID so that we could find those patients and then pull them in, knowing that we could use them as for COVID research purposes. So you can imagine that this was very difficult in the very beginning of the pandemic when everything was so uncertain and people really just weren't sure what was going on. As the pandemic went forward and we got a handle on definitions for COVID, this piece got a little bit easier. And so at a high level, our current phenotype looks for patients that have a positive COVID test, could be PCR or antibody, we're okay with either, or antigen, I should correct that, or have an ICD-10 code of U07.1, which again is the ICD-10 code for COVID, or from the very beginning of the pandemic, before that diagnosis code existed, have 2 or more COVID-like diagnosis codes, things like acute respiratory distress, pneumonia, et cetera, during the same encounter. Now, that's a very broad criterion that we would never want to use now because we would pick up everyone with a cough. But back in January, February, even March of 2020, we really didn't have a choice. And so that's where this criterion comes in. And then each one of these patients that is caught by this logic is then demographically matched to 2 patients that have either negative or equivocal COVID tests and no positive tests. Now, the reason that I said I was going to discuss this in more detail at this point is because we don't think that this logic is working very well anymore, which is very interesting because the pandemic has evolved over time. Because there are so many home tests now, and that's how most people I know test for COVID these days, we can't guarantee, we never could guarantee, but we certainly can't guarantee now that the people in the control group actually never had COVID. We like to more consider them as people that we don't know had COVID. We just don't have enough information about them. So I did want to caveat that this science of phenotyping COVID in a computable way is not something that we wrote in 2020 and it's never changed since then. We know that just like the pandemic has evolved, so does this science of phenotyping also needs to evolve. And then finally, once sites are ready to actually define that population in their local EHR data, they can then extract all of the EHR data that they have available for that patient population and send it to our secure server at N3C, where we do all kinds of parsing and mapping and quality checking. And we manage to put it all into the OMOP data model, which then becomes the N3C release data set. And that is the data set that contains all of the EHR data for all of those COVID patients and their matched controls from all 77 sites, and again, is refreshed weekly. Now, when we're harmonizing all of that data together, there is absolutely going to be harmonization challenges, and I think that that's been one of the most interesting non-clinical aspects of doing this work is that, you know, I'm sure you all have been exposed to the idea that data cleaning is usually the hardest part of this kind of work, not actually doing the analysis. And when you have 77 different sites with 4 different data models that you are trying to put into one big database, all of the data cleaning problems that would be true at local institutions are compounded by an order of magnitude. And so for at least the first 6 months of N3C, our entire job was essentially cleaning up the data and getting it ready for research. At this point, though I would never say that we're done with data cleaning or done with data quality, I think we've stabilized to a point where people are starting to feel very comfortable using it as a research data warehouse, which is exactly what we wanted. So that was all setting the stage to talk about long COVID specifically. So N3C was built for COVID research. There's been a ton of COVID research done with N3C. There's been something over 50 publications in the last few years, really amazing work by hundreds and hundreds of researchers, and it's been really gratifying to see. But as soon as NIH decided that they were going to put a lot of funding and energy behind researching long COVID specifically, when long COVID, when it became very evident that it was not going away and that it was really truly affecting patients' lives and their abilities to get back to their lives pre-COVID, that's when we decided that N3C was an ideal home for that kind of research because of the number of patients that we had, as well as the geographic and demographic diversity of the population that is part of N3C. But long COVID is a particularly challenging problem in that it has a ton of potential symptoms, many of which are not related to each other or seemingly not related to each other, and many of which are also present in plenty of other conditions. So this diagram that you're looking at here would be a lot larger if we updated it for the most recent work. This was only 2020 and 2021 work, where one of our collaborators actually inventoried all of the different symptoms that were listed in every paper that she found about long COVID and tried to categorize them. Now you can see how long, ridiculously long this list is. And even the list of categories is really long and seemingly unrelated. And because there are things that are so common in other diseases, things like abdominal pain, fatigue, respiratory issues, you can't just find a patient that's complaining of one or more of those things and say, oh, well, they have long COVID or they don't have long COVID. What we realized is that we were going to need to take a much more complex approach in order to avoid labeling patients as having long COVID that did not have long COVID, or the reverse, not finding patients who should be labeled with long COVID because we're just not finding the right patterns. The NIH Recover Initiative is the name that the NIH has given to their umbrella initiative to study long COVID. And N3C is fortunate enough to be a part of this. There is an entire EHR and real world data component of the Recover initiative that includes N3C and other EHR data repositories, where we can do work that is specific to data science and can contribute to the long COVID fight in a way that is only possible through data science. And one of our first tasks that was given to us by NIH was, let's try and figure out if we can define what long COVID is in data. And that was a huge challenge because we had the issues that I mentioned before where the symptoms are diffuse. And even today, there is not really a satisfactory definition that is simple and easy for long COVID. We're smarter about it now, we know more about it, but we are far from having stringent criteria that you can point to and say, if a patient has this, this, and this, they have long COVID. And so this was truly an informatics puzzle. Now, we were, again, using the OMOP data model, which gave us a lot to work with as we were looking for long COVID patients. So if you're not familiar with the OMOP data model, it contains, I would say, maybe the top 75 or 80% of the most commonly requested variables in EHR data that are used for research. It doesn't have everything recorded in the EHR, but it has a lot of the most important things that we use all the time. Things like conditions or diagnoses, drugs, procedures, exposures to devices, which can include oxygen support, which is very important with COVID, lab results and vital signs, other clinical observations that don't necessarily fit very well in other places, visits, so data about who was hospitalized and who was not hospitalized. We have data about mortality, as well as demographic information about patients. So we, my collaborators and I sort of went through this menu of variables and decided that we wanted to put together a feature table for use with a machine learning algorithm that was going to try to not put our thumb on the scale too much. So we weren't going to pick and choose which variables we wanted to put in the feature table, but we were going to try to be smart about it in that we weren't going to throw in the entire OMOP data model, but rather choose from the things that we felt were the most important in order to define long COVID. And those things ended up being, for us, conditions and or diagnoses and drugs. And so those are the two categories that we used when building our long COVID model, which I'll tell you about in a moment. A lot of folks have asked why we didn't use lab results and vital signs, and I think that's a very valid question. And my answer is that there is an enormous amount of missingness in lab results and vital signs from patients who are not hospitalized. So if you're hospitalized, we have a ton of information about your lab results and your vital signs. But for patients that never end up hospitalized, though we do have lab results from them, we have far fewer. And there are many labs that are unique to inpatients that would just never be pulled on an outpatient. And for that reason, the lab data was so sparse and so heavily missing that it did not end up adding a whole lot to our model. So we stuck with conditions and drugs. We then needed to select a cohort, and as part of that cohort, we needed to select a training set, test set, and all of that good stuff that you do when you're doing machine learning research. But again, we had this challenge where there is no definition for long COVID. So who do we pick? What do we train on? I'm going to tell you about what we did originally, and this is the method that ended up in our publication on this work. We have since improved this method. You know, COVID research moves very quickly, and so things change even within 6 months to a year. We have a better method of doing this now, but I will walk through the original method. We have a number of our academic medical centers that contribute to N3C that have long COVID specialty clinics on their sites. And those centers that have long COVID specialty clinics often record if patients specifically visit that clinic versus an ophthalmology clinic or an endocrinology clinic. And for a few hospitals, not all of the 77 N3C sites, but a few sites were willing to share with us which patients of the patients that they submit to N3C had gone to the long COVID clinic. That meant all we knew is that those patients had gone to the long COVID clinic. We didn't know if they were diagnosed with long COVID. We didn't know what the result of that visit was, but we did know that they were referred to that clinic by another physician or that they themselves sought care there, suggesting that there was some long COVID signal to be had from patients who visited. And so that is what we opted to use as our training set initially. where patients from 3 of our sites had long COVID clinics. And then we ended up training our entire model on that. So you can see that the numbers get pretty small pretty quickly, in that all of the patients from the 3 sites with long COVID clinics at the time were almost 100,000 patients. But by the time you break it into patients who were hospitalized and not hospitalized, who we felt looked pretty different and therefore necessitated their own models, the numbers of patients who had visited the long COVID clinic versus those who did not were getting pretty small. And so this is another one of the reasons that we ended up optimizing this in a future round. But I wanted to talk specifically through the way that we originally did it, mostly to show how desperate we were for something to hang on to in the data to test and train on. There really wasn't any other option that made any sense. Now, what do we do that's better now? In October of 2021, the ICD-10 code UO9.9 was made available for use in the US to actually provide a diagnosis code for long COVID. So when we were doing this, there was no diagnosis code for long COVID, did not exist. There was no way of doing that. And so it really wasn't until almost 2 years into the pandemic where this code for long COVID was made available. And what this graph is showing is the frequency of the use of various codes for long COVID over time. As I mentioned, there wasn't a code for long COVID prior to October of 2021, but there was this other code, B94.8, that was not for long COVID, but it does appear that physicians were using it that way because it is the code generically for sequela of viral disease. And so you can see that over the course of 2018 and 2019, that code was in use, but it was very uncommon. And then it's starting in 2020 as the pandemic starts, you can see more and more people are being assigned this B94.8 code, but we can't really rely on it that it's actually COVID because, again, it's a generic code. And then you see as we get into 2021, this UO9.9 code starts to supplant B94.8 as it becomes available for use. And now, if this graph extended out further here later into 2022 and even into 2023, you would see that it is at this point almost exclusively UO9.9, and it's in much higher volume. So because of this overall increase in volume over time, we have been able to now switch our training set. So instead of people who visited a long COVID clinic, we are now using patients who have received this diagnosis code, which gives us a much stronger indication that the patient actually has long COVID, as it's a little bit more certain, and we feel pretty good about that. So we trained an XGBoost model on first our long COVID clinic training set, now our UO9.9 training set. And we used to run 3 separate models. We used to have a model for non-hospitalized patients, for hospitalized patients. And when I say hospitalized, I mean specifically hospitalized with their acute case of COVID, and then a model for all patients. For simplicity purposes, because we run this model all the time now, at this point, we are only running the all patients model, but it was really interesting to see the differences between the hospitalized and non-hospitalized models when we were originally doing this work. One of the things that you'll notice is that because there is more data available about hospitalized patients, we simply collect more data. The performance is better than patients who were not hospitalized for whom there is simply less data available. So I can walk through these chat plots quickly, but these are the chat plots that were published in our original publication that showed the most important features in each of the models that I showed on the prior slide. Because this is outdated now, I'd rather show you the chat plots for our UO9.9 trained model, as this is the latest and greatest. And what you're looking at here are the 25 most important features that the model hangs on to make a determination as to whether a given patient should be classified as long COVID according to its logic or should not be. So let's just take dyspnea for an example here to show you how to read this if you're not familiar with reading this type of plot. Dyspnea is either a 1 or a 0 in this data set. You either have it or you don't. If you report it, that means that your value is this red color. It's a high value as opposed to this blue color, which means 0, you don't have it. If you have it, if you have are in the red area, then the model is much more likely to classify you as positive for long COVID. If you have a blue, if you're in the blue area, the model is now more likely to classify you in the negative area. If you have a lot of inpatient visits in your time, in your longitudinal history, you are actually less likely to be labeled as long COVID, because the model, we think, sees you as somebody who is often hospitalized for other things other than long COVID. Couple other examples: if you get a new prescription for an asthma inhaler, you are more likely to be labeled long COVID. If you complain of malaise, palpitations, chronic pain, etc., you're more likely to be labeled long COVID. So one thing that I like about looking at the data this way is that you can see, with a couple of exceptions that look a little funky, because machine learning algorithms against clinical data always look a little bit funky. Most of the stuff makes common sense when you think about what's in the literature about the most common features of long COVID. But because we're using a machine learning model, it's not that the model says, oh, you have dyspnea, you definitely have long COVID. Rather, it's a combination of your values for all of these features, including less important features that are further down the list, that all contribute to the model making a decision. And that feels more like the multi-systemic nature of long COVID, where it's not one thing, it's maybe 5 things or 10 things. And this method allows us to kind of get at that multi-systemic nature. And just to sort of show that these different features can sort of push and pull the model's decision making, these are plots that really just illustrate that, you know, if you, for example, have a record of the COVID vaccine, the model is actually less likely to label you long COVID. Whereas if you have high post-COVID outpatient utilization, the model is actually more likely to push you to the long COVID side. So we tried to produce as many visualizations as possible to make this as explainable as possible, particularly when we're working with audiences that are not machine learning folks, that are not artificial intelligence folks. We want to make sure that this kind of passes the sniff test of, you know, is this, does this seem like it follows common sense? Would you want to use this in your clinical data? Would you trust this? And I think in order to answer those questions, machine learning has to be explainable. There are caveats and limitations to this work, as there are with any machine learning work and really any science at all, but these are the most important ones. Electronic health record data only represents patients who have access to care and choose to seek care or are able to seek care. That means we're leaving out an enormous portion of the population that can't afford to see the doctor, can't get time off of work to see the doctor, and just aren't in the data. That means that even before we've even clicked one button on our keyboard, things are already skewed and biased, and that's something that we have to keep in mind. Likewise, although it's slightly different in nature, EHR data also skews towards sicker patients. So you saw how our inpatient or hospitalized data-based model performed better than our non-hospitalized model. It's because there was more data available for the patients who are sicker. And so that's another skew that we have to really keep in mind. This model does not address subtypes of long COVID. And that's an increasingly important area of study and something now that we're working on as part of the Recover Initiative, in that not everybody has the same kind of long COVID. And in fact, our model, we have been told by patient advocates and feel ourselves, really stresses pulmonary conditions, asthma medications and shortness of breath, and lots of different pulmonary and respiratory features are really important. And what we've come to realize is that that's because a lot of the physicians who are specialists in long COVID and are treating these patients are pulmonologists. And so they themselves are leaning towards pulmonary diagnosis codes, which means that's what's feeding our model. So you can see how easily these clinical models can become biased in ways that you wouldn't have ever expected, but how that bias can just keep getting pushed forward without even another thought. And we have to keep these things in mind. And then finally, what I think is maybe the most important caveat is that lacking a long COVID label, so not having that UO9.9 diagnosis, not visiting a long COVID clinic, for the purposes of a machine learning model, we have equated that with not having long COVID. You don't have the label, you don't have long COVID. In reality, that is almost definitely not true. There are definitely patients who have long COVID that are simply not labeled that way. And those patients are certainly floating around in our data and maybe, in either side of our model. And we have to keep that in mind as well and use new methods to work around that in the future. I want to acknowledge the massive team of people that have done work on this and continue to do work on this, including our long COVID phenotyping team, the entire team that built and continues to maintain N3C, and also our funders at NIH. And I will be happy to take any questions that you may have. Oh, I think you're on mute.
Oh, sorry. Thanks, Emily, for a great talk. Are there any questions from the audience? No. Okay. So I've got one question. Like, in the last points that you mentioned about biases, did you is there a way that we can really, address those biases? Like, have you really thought about it?
So I think there are some things that we can do, and I have to admit that that is not my area of expertise. So there are probably people that would have a much more satisfactory answer to that than I will. But one thing that we can do, for example, is we chose deliberately not to use race and ethnicity as features in our machine learning model. And the reason for that is that if, as it does seem to be the pattern, there are an overrepresentation of white patients in the positive long COVID category. We didn't want the model to make an assumption, that white patients are actually more likely to have long COVID. That's a data artifact, and sort of going back to that idea that the people that we have EHR data about are the people that seek care the most. And so we tried to kind of keep the model neutral that way, but we always understand that models aren't neutral because the data itself is biased. And so, I think that that's one of the challenges that we're going to have to continue to face is reduction or removal of bias in machine learning over time.
Okay, thanks. Anyone else have a question? No?
I see there's a question in the chat that I can read.
Yep.
So if a patient gets a positive test of COVID several times, will you define this case as long COVID? So that's an interesting question. We have realized now that the model is probably doing that for some patients, and we actually don't want that behavior. So so when we built this model, it was pretty early in the pandemic still. I think it was late 2020, early 2021. And at that time, if you remember, most people weren't getting reinfected with COVID. You had COVID, and then you pretty much just had it that one time until Omicron came around. So when we built it, we weren't really thinking about this idea that you could just keep getting regular COVID over and over again. Now, of course, we know that's the case, and people are getting COVID over and over again. And so we are currently talking among our collaborators to try to adjust our model to not confuse a new COVID infection with long COVID, because we don't want the model to make that mistake. And I'm worried that it might be, because if you get COVID again and you go to the doctor because you are complaining of shortness of breath, our model will see shortness of breath that happened a long time after your first COVID and could potentially accidentally label that long COVID. So yeah, that's a really, really a good thing to point out. And then your other question, first feature in the chat plot is age. It seems the age in a relatively high level are more likely to get long COVID. How to explain this? So age in that shot plot has a nonlinear relationship to the yes, long COVID category. And it's so nonlinear that it's really difficult for us to say that this certain age is a lot more likely to get long COVID versus this other age group. Um, it's very hard to interpret that way. It is an important feature, however. Our model does tend to think that middle-aged patients are probably more likely to get long COVID, but that's not 100% true. So that particular feature has been one of the hardest for us to explain in at least a satisfactory way.
Thanks. Any further questions?